Let us move to the last 5 cranial nerves. Vestibulocochlear nerve, as the name indicates, it has two components: vestibular part for the balance, cochlear part for the sound, and these two parts, they are supplying the inner ear. The cochlear nerve, it is present in the modulus. The cochlea, it's like a snail, a spiral that moves up, and inside there is a cone like bone around which the spiral is building up. This cone, this cone is called modulus. This cone is called modulus around which cochlea is moving up. The spiral ganglion, the cochlear ganglion, is present there. And as you can see from this picture, these are bipolar cells. The dot is showing the cell body. This is the peripheral process, this is the central process. The peripheral process, it is getting signals from the hair cells of the organ of corti, and the central fibers, they are making up the cochlear nerve that will move along the fibers, and the central fibers, they will end in the two cochlear nuclei inside the brainstem, anterior and posterior cochlear nuclei. Vestibular component. Vestibular component is coming from the utricle, saccule, and semicircular canals. These cell bodies are located outside, a little outside the inner ear. No, I mean little outside the vestibule. In the inner ear, that is the vestibular ganglion. Again, it's a bipolar cell bodies are there. The central processes are going to the vestibular nuclei, and the peripheral processes are coming from the sensory organs, from the vestibular organs like utricle, saccule, semicircular canals. And there are four vestibular nuclei: medial, superior, inferior, and lateral. So this is internal acoustic meters. Vestibulocochlear nerve exits, not exits, enter the internal acoustic meters and exits and go to the pontomedullary junction, the laterally, pons and medulla junction. And then there is vestibular nuclei. There are four in number. These both sensation will be special somatic afferent, SSA, special somatic afferents. The vestibular nuclei, there are four in number, shown as a common nucleus right here, but actually there are four in number. They are getting input from majorly from the vestibular nuclei. These are vestibular nerves, cranial nerve number 8, and they are getting direct input from the cerebellum also. That you have to remember that. These vestibular nuclei, they give output, they give efferents to the cerebellum. For the conscious perception, you get dizziness, you get sensation when you are moving around. So this is the cerebral cortex, and then it is going to the medial longitudinal fasciculus for the vestibulo-ocular reflexes, and then there is fibers going to the vestibulospinal tract for the balance that are making you stand, vestibulospinal tract. So these are the vestibular nucleus and its connections. So talked about ascending fibers, and you must always remember that the ascending fibers always relate to the thalamus before going into the cerebral cortex. Auditory pathway is now in the part of the discussion. So like you can see, the spiral ganglion cells, these will be the first order neuron present outside. They are receiving from the receptors, hair cells. The central processes are fusing ipsilaterally with the cochlear nucleus. Posterior and interior cochlear nucleus, these will be the second order neurons. Okay, you don't have to remember first and second order neuron itself, because there are multiple relays and the theory does not hold very strongly for that. And from the cochlear nucleus, the fibers, they go and synapse with the cell bodies in either trapezoid body and body here. They're shown as a trapezoid body and superior olivary nucleus. They're shown as a common item, otherwise they are different things. They're schematically they're shown similar, but they go on either side. More fibers go to the contralateral side than ipsilateral side. Then from the trapezoid body and the olivary nucleus, superior olivary nucleus, they move up, and the moving fibers up, these are known as lateral lemniscus. Lateral lemniscus may have some relays within themselves. These are nuclei of the lateral lemniscus, but you can ignore that. The major relay come in the inferior colliculus. Remember, the superior colliculus one was the one that was with involved with the visual reflexes. And here is the inferior colliculus, that is the relay. And inferior colliculus then gives signals to the medial geniculate body. Again, compare it with the lateral geniculate body, that was for the visual pathway. And this part, that from inferior colliculus to the geniculate body, this is called inferior brachium. And from the inferior geniculate, lateral geniculate, and from the medial geniculate body, the part that goes to the brain is called auditory radiations, acoustic radiations. And they go to the superior temporal gyrus, superior temporal gyrus of health, lateral sulcus के फ्लोर में होता है, superior gyrus के रूफ में होता है, and this get there, that's the primary auditory area, and then they go onwards. So that's the basic auditory pathway. So with that, we have already almost done the vestibulocochlear nerve. Any injury to the vestibular nerve, any disturbance will lead to vertigo, that is you feeling loss of balance. Nystagmus, your eyes have a pendular movement. They go slowly in one direction and fast in other directions. They move away from the lesion. I'm not going into the detail of the functioning of the vestibulocular reflex. Otherwise, that's another interesting topic. We can have that discussion otherwise. And vestibular nerve may be damaged to the any injury of the inner ear. That is the diseases of the labyrinth, Meniere's disease, the lesion of the nerve itself, the vestibular nuclei itself, the cerebellum itself. The cochlear nerves, it will lead to deafness or the ringing sensations in the ear known as tinnitus. And it can be from all the way from hair cells to the cerebral cortex. The injury can be anywhere. And any injury from the hair cells, from the sensory organs to the cerebral cortex, that will lead to sensory neural hearing loss. The conductive hearing loss will be the one anything before the cochlea, that includes the external ear, the opening, the eardrum, the middle ear, the ossicles, the oval window, foot of stapes, otosclerosis. Those will be conductive causes. Anything from cochlea onwards will be sensory neural causes. Inner ear will be affected in Meniere's disease, labyrinthitis, that is the inflammation of that, trauma, injury, congenital absence, congenital issues, tumors that can affect the cochlear nuclei, especially acoustic neuroma, also known as schwannoma, and tumors. And then there are tumors of the midbrain, multiple sclerosis that may affect those areas. And always remember that any injury before here, complete injury in the cochlear nerve will need to complete deafness of that ear. And any injury after that, even if that this is damaged, the lateral lemniscus is damaged, the inferior colliculus is damaged, or any injury above that, it does not lead to the complete hearing loss, because this point is to be remembered that all the fibers, they ascend bilaterally. Most fibers on the contralateral aspect, some fibers on the same aspect. So any injury in the any of the higher areas, it leads to the partial hearing loss that is more prominent on the contralateral side. So that is the auditory pathway. That is the lesions, and with that we are done with the